Hello, welcome all. Continuing the Retrograde CTO Academy, today I would be discussing about the kissing wire technique or what we call as a marker wire technique. So this is one of the, I think, simple most out of the four techniques of retrograde CTO. And this is the technique where the beginners should start with this particular technique that is called as a kissing wire technique or retrograde marker wire technique. So I would be discussing this as a case-based discussion. And first of all, the things that should be kept in mind is that there are basically four ways to get the retrograde technique successful. First of all is the kissing wire technique. In this, the integrated wire is negotiated while keeping the retrograde wire across the collateral into the main distal artery lumen that will act as a marker or guiding wire. This is also called the kissing wire because the tips are very near to each other, and the retrograde wire, which is in the true lumen, will guide the antegrade wire towards the true lumen. Sometimes we are able to get the retrograde wire back into the antegrade lumen. This is called a retrograde wire true lumen to true lumen crossing. And third is the control antegrade and retrograde tracking, that is SCAR technique. And fourth is the reverse SCAR technique that I will discuss on the case based basis. So coming on to the first case, in this case, we can see that if you have 100% RCA CTO, then we can try the antegrade wire. If it is not going, and if we have a good collaterals from LAD, either by septal or epicardial, then we can keep this wire shown in the green as a distal marker to guide the entry of the antegrade wire into the distal true lumen. So coming on to the case, this is the case history: 55-year-old male, non-diabetic, non-hypertensive, stable angina. He has a ejection fraction around 40%, and this hereditary was hypokinetic. So the patient underwent this angiogram in March 2021, but it showed the CTO of LAD as well as the RCA. So this is how the angiogram is. So we can see the LAD is 100% occluded in mid portion, and as well as the RCA is also having the 100% occlusion. So first, the LAD was this negotiated anti-gradely with the microcatheter over the filter XT wire was taken, and the PCI to LAD was done. Now, after 1.8 year, the patient presented again with angina, and he had a residual disease RCA-CTO. So this is the RCA-CTO we can see, and this is how it is filling retrogradely with very good collaterals. That is, we can see in the RA caudal and the epicranial view, we can see we have a good collateral, but they are coming from a jailed septals. So in this particular case, we can see although the collateral is good, but it is coming out mainly from the behind the stand. So it's called a jailed septal collaterals. But the lumen is good, although they are a bit angulated in the mid to distal part, but they are good continuous collaterals. It is CC2 Burner collateral. So as usual practice, integrate guide was taken, and this over the filter XT, over the help of microcatheter, this was taken. But the problem is that due to the ambiguity, we can see that there was a branch at the particular point, and it was not the wire was going again and again into the same branch, and it was not going into the true lumen. And in this, when we have got a branch, we cannot go with this any escalation would not help here because we are not able to get the point to poke. So in this, now we plan the retrograde gear was taken, and in this, across the stent, we took a Corsair Pro Axis catheter, and Xion wire was tried. But problem in that it took the wrong septal and it went into the free space. Then it was tried to negotiate the mid septals, mid part of the this you can see in this image. Across the jailed septal, the microcatheter was negotiated across the struts, of the LED stent. Even without dilatation, the catheter went in a smooth fashion, and we tried the filter XT wire to go through the septals. But the problem was that the wire was still not going into the lumen, because we can see there is a reverse S-shaped bend. We can see from the microcatheter tip just distal to that, there is a reverse S-shaped curve. So this was the point where I thought that we should change the wire. So SUO3 wire was taken to negotiate this particular bend, and it took a reverse bend, and it has a very low tip load of 0.3 gram. It's a soft wire, and it went into the this septal collateral, and we could negotiate into the PDA into till the mid RCA. The Corsair Pro was taken, and XTR was taken now to cross the distal lumen. But problem was there was a bend, and there was a lot of calcium on the distal cap. So keeping this distal microcatheter at the distal end and negotiating the antegrade wire to keeping the distal microcatheter as well as the wire in the true lumen, it acts as a marker or a kissing wire. So this is what the marker wire technique is. We are putting a distal retrograde wire into the true lumen and taking the proximal wire and trying to negotiate by seeing the distal wire as a marker. So in multiple views, AP and RAO and LAO, we can see the antegrade wire was able to, we were able to get over the fine cross microcatheter into the distal true lumen, and the microcatheter retrograde gear was withdrawn a bit till the distal part of RCA. And over this, then where 1.25 millimeter balloon was taken over the antegrade wire, and this was pre-dilated. So this is what we did in this case. We went from LED septal collateral to the PD, then to the mid RCA, then keeping it as a marker, we negotiated the antegrade wire into the true lumen. And after that, two long discs were implanted, and this was the final result. So good TME3 flow was obtained with the usage of the retrograde CTO technique, that is the marker wire technique or kissing wire technique. So, take home from this case is that many times we can get dual CTO. So, we can deal the first CTO first, the second afterward. So, in this particular case, integrated CTO of LED was done, and we got a stent in the LED. Then we can, with the newer microcatheters like Corsair Pro XS, which are thin profile, 1.3 French distal tip profile, we can negotiate across the septal, this jailed septals across the stents. And many times, if we get the reverse S-shaped bends, we can use the SUO wire and a filter XT to negotiate this towards collaterals. And in case of ambiguous cap and branch at the CTO, often the integrate approach would not suffice, and we would need a retrograde approach. And in this particular patient, we had a good CC2 collaterals, so that helped as a distal marker wire. And the meticulous planning of crossing intervention collateral was needed. And hardware knowledge is the key to perform the retrograde PCI. And this kissing wire technique or marker wire technique is one of the first technique that a retrograde operator should adopt, because this is a bit easier as compared to the reverse card or the knuckle card that we will discuss later. So thank you all for patient listening, and I would be coming in the next session, that is session 4, with the discussion about the crossing from the retrograde wire coming from distal lumen to the proximal lumen, that is wire to wire, distal retrograde wire lumen to lumen approach. Thank you.